So thank you everyone for attending this session. We'll be talking about the impact of Alzheimer's disease in the African American community. I'm sure my colleague has done a phenomenal job talking a little bit about Alzheimer's disease. So I'll be talking a little bit about how it impacts a particular culture. If you go to the next slide, I want to start off, and this is an engaging presentation. So I do want to have a little bit of activity. Obviously, we know the disclosures. Obviously, no disclosures have been identified. No conflicts of interest has actually been noted as well. If you go to the next slide. So a couple of things that we will be doing. We will be, and I'm going to move this over so that I can see everything. Okay, there we go. Discuss the concepts of cultural competence in relationship to healthcare research and the community. Will also identify cultural influences on your beliefs as well as your values. Describe the term cultural compatibility. I don't know if you all have heard of that. And the impact of healthcare research and the community. And then also evaluate the role culture plays in determining how different people perceive and shape their world. Next slide. So on this slide, we want to bring up those letters that many of us are familiar with, and that's called COVID-19. And I want to bring this up because we want to talk about how this has actually truly impacted the African American community, all communities, as well as, unfortunately, the disease that we'll reference. So a couple of things that I want to point out is COVID-19 has caused an amplification of culture in our society, our community, our family, and work, and in regards of ourselves, the individual. I want you to keep these terms in mind as we begin to reflect on them, because I want you to think of what your society consists of, what your community consists of, family, your work environment, whether that's the work environment at home, and also you as an individual. I want you to think of those things as we go through this presentation. I also want you to keep your thinking caps on, because I want to share this with you. Ironically, I presented this 1.5 years ago to a totally different group of people, and I was amazed at their perception on some of these things. So I'm going to get the same thing from you. I want to feel what your perception is on a case scenario that I'll be presenting towards the end. So again, think of society, community, family, your work environment, and that may have changed, as well as yourself. Next slide. So culturally safe communities, this is what we're going to think about. In a culturally safe community, we know these vulnerable populations are at risk of experiencing inequitable health experiences and health outcome. When I think of those terms, I think of what we are seeing all too far right now, especially at the federal level, and that's health inequity. How many of you all know what health inequity is? Could you elaborate? Absolutely. Great. I love the fact that one of our participants pointed out health inequity, but I also want to talk about the difference between health care and health inequity. So with health care is what she probably focused more on, but health inequity is not having the same opportunity from health care versus actually not having the same opportunity based on the disease that you may have. And we'll talk about that in a moment. Vulnerable populations are exposed to research that is driven to socio-cultural lenses. And again, when we think of that, we just talked about this when we talked about COVID-19. We wanted so many of our vulnerable or disproportionate populations to be involved in research. And how is that, you ask? Well, if you ask a person to take a vaccine that they're not well known, that has not been on the market for greater than a year, they consider that research. To us as healthcare providers and researchers, we consider that healthy, maintaining, and maybe saving lives. But to a different cultural group, especially a disproportionately underserved population, they see that as research. So I want you to think about that. And then also when we look at dominant culture, now, one of the things I want to ask you, again, here's another engaged question. What is culture to you? Does anyone want to elaborate on that? What is culture? How do you define culture? More. I love the fact that she said that. So think about culture as a group of people who have common or shared experiences or shared some obviously surrounding. It could be religion, it could be age, it could be resident, it could be socioeconomic status, but the most dominant, and this is what the government brings up when you look at the census, the first thing people think of when they think of culture is ethnicity and race. They never think of resident, socioeconomic status, religion, etc. So because that's so prevalent, especially not only in the community, but also in healthcare, this is what we'll be talking about when we talk about culture. So keep in mind, culture can mean so many different things. Actually, it's 240,000 or so many different definitions of culture on the internet. But we focus on race and ethnicity because that's what our society sees. Yes.
I just want to add in that word dominant there, dominant culture. It then comes to norm.
Yes.
You have to fit within this norm.
Yes.
That has been defined as dominant culture.
Absolutely. And once again, when we also say census, the first thing people talk about is ethnicity. They don't even look at all of those other things. So that's what we're going to be talking about when we look at culture. Next slide. So how do we define culture? I just talked about that. We can look at it in society, we look at our community, we look at our family, we look at our individual. And society has brought us so close together just recently due to COVID-19. But society does not bring us together when we talk about Alzheimer's disease and related dementias, because they think of that as a what? Community. They think that's a community problem because that's what they have to deal with in the older age population in Santa City. Or that's a family problem because that person has, or that family has a history of Alzheimer's disease-related dementia. Or that's just that person's problem. But they don't realize that it's a societal concern and we have to see it as such. Next slide. So culture, I just said it, I said 240,000. So it's 1,460,000,000 is off of that. So that's what culture is. It describes the sum total population of all the different characteristics, everything that exists throughout that person or that individual that obviously see. You know what I always think of when I think of culture? I think of culture starting off with the bio, psychosocial, cultural, spiritual being. That's you as the individual, but yet you have all of the things that surround you. And if you're walking into that environment, if you're walking into that clinic, if you're walking into that community, you have all of the things that surround you to support you. And as a healthcare provider, that's what we must see, not just this person that walks in with some type of cognitive impairment. Next slide, I got to get to these because I got to get to that scenario. So this is something I want you to kind of look at. As a healthcare provider, as a community person, and I see that we have a large number of healthcare providers, I hope in some community, what I want you to see is think of these steps to cultural competency in order to understand the individual, in order to be culturally competent. And as you all know, competency does not mean an expert. I've had people come up to me and some of my colleagues, oh, you're the expert. We are not experts. If we were experts, we've written every book and we know what it says. We are only knowledgeable in the subject area. So to be culturally competent, one must actually experience, and I share this with my students, have their personal heritage, know who you are. What is your heritage? What is your health beliefs? Then you can actually identify the heritage of others. What is their information, their family, their community? Then you go to the beliefs and practices and obviously the philosophies of those individuals. The philosophies can be related to having a rainbow celebration down the street. What is their philosophy of cultural competence and health? Having an environment where there's older age people. What is their philosophy? Going to a worship place. What is their philosophy? Having a group of African American or Native Americans together, what is their philosophy? That's what you want to think of when you think of the practices and beliefs. What is their healthcare culture and systems? What does that look like before we actually identify a person and recognize their cultural beliefs? And more importantly, what is the traditional healthcare system as it relates to that individual, family, community, society, right? So we want to look at all of those things when we think of cultural competence. Next slide. The process. Now, this is actually Josefa Compata. She is actually a philosopher and a theorist who talks about cultural competence. I love her theory because she really goes into the process of humility. Is competence and humility at the same time. Knowing that you understand, but you're humble enough not to share as much information because you want to have that question. And that question is always, even though I see you as an African-American female, tell me who you are as a biopsychosocial, cultural, spiritual being. Because you are not just the African-American female that she is, you are totally different. So we have to understand who you are. So when we do that, we're actually being aware, culturally aware. We're actually trying to gain some knowledge. We're actually building skill by interacting with them, having an experience, which is the encounter. And the most important thing, you have the desire. You can't, as a healthcare professional and a community person, when you're working with any type of individual, you can't go in, as we call it, fake, right? Because the person and the environment picks up on that immediately. So what this person does is she created what is called, and I love to switch it around, is asked. She's basically saying ask the question in regards to those things. Next slide. So cultural awareness, and I will just kind of touch on these because I really want to get to the meat of this. Cultural awareness is the process in which one conducts a self-examination. Who am I? You know, I could tell you, and I'll quickly share the stories. I work in a clinical environment. I remember years ago, I'm from Michigan, and I moved out here in 05, 06. And when I was here in 06, and it's ironic, I have a yellow outfit on, but before I worked at Banner, and I still do, but it was interesting. I had on a yellow uniform, and this was before we could even wear color uniform. We only wear navy blue, but back then I could, you know, if you know me, I wear my sharp uniforms, match with my shoes and all that stuff. So I had on this yellow cute uniform, and I walked into this patient's room who had some cognitive impairment, and I knew that. I had a nurse assistant who was with me, and she was a Caucasian nurse assistant. We were walking there, we talking with everything, and then the patient looked at me and she says, "Oh, I really love your colors." I had on all yellow shoes too. And she said, "I love your colors." I said, "Thank you." And she said, "You know, brown and yellow looks very good together." Now, mind you, when she said that, my assistant said, "Oh," and I said, "Oh, does it? I'm going to start wearing it more often." And everyone around me was just freaking out. Someone else walked in, the dietitian said, "Oh my God." And then what I said to her and the others, I said, "I know who I am, and I know her disease." So for her to compliment me that way, that was respecting. She was respecting me, and I accepted it. So, and when you know who you are, you're culturally aware of your environment. And I love to see the smiles on your face when I say, you know, that you are that biopsychosocial, cultural, spiritual being, right? Okay, next slide. Knowledge. It's the process in which healthcare professionals seek and obtain a sound educational based on cultural diverse groups. You, just because you are a healthcare professional, a physician, you're not going to say, "Oh, I know you have diabetes," or "I know you have Alzheimer's disease. Let me figure it out." The elephant in this room is, I know who you are, and then I know who I am. So let me figure out how to care for you. I'm working on a research study right now at Banner University. And what we're working on is discharge planning on culturally appropriate discharge planning on patients with diabetes. You cannot tell a person who has diabetes that these are some of the foods that you cannot eat, and then they go home and eat candy yams. And they don't understand that the person, the particular, let me go, African-American person, that's their dish. That's something that they have in their family, right? Teach them how to cook the candy yam so that they obviously won't have complications of blood sugar. So that's, again, culturally appropriate discharge planning in the dietary area for diabetes is something that we're focusing on. Same here, knowledge, being able to learn about different cultures so that you can understand them more appropriately. Next slide. Skills, having the skills, the ability to gather culturally relevant data, getting the information, asking questions. Data come in two forms, quantitative and qualitative. It can be the numbers. What's the percentage of individuals in this particular culture that does this? It can be in qualitative, which is one I like. You can obviously see that. Interviews, focus interviews, individual interviews to learn about the particular culture. So that's how you gather skill in the particular culture. Next slide. Encounter, most important. I can have so much textbook knowledge. I can have so much information that has been gathered from all of my workshops, webinars, zoomed out. But if I'm not interacting, and now that we're able to interact in these environments, it's nothing, it's null and void. So it's the engaged face-to-face activities, really experiencing certain things. And this is where we want to make sure that our healthcare professionals and our community members are involved, as evidenced today. You know, I love the fact that we have some people on the Zoom, but just being in the room and seeing the interactions and the experiences that people have actually shared, that's an encounter. And the last one, which is the most important, is the desire. You have to, next slide, you have to want to know. You want to be motivated. You want to engage in the process. It's not because, oh, I'm just here. I have a really, really, really good friend who I work with in certain projects. No, I'm not going to say her name because she may hear me. And I love the fact that she has a passion to work in the community. The people don't have to look like her, but the fact that she's making an impact in the community is the most important thing right now. And that's the desire. That's what you need when you're working with that. Now, I gave you a little bit of an understanding from a particular theorist on what cultural humility is. Let's go to the next slide. I want you to, these are things you want to do. I have asked myself these right questions, and I'm sure you've had access to this information. Am I aware? Do I have the skills? Do I have the knowledge? And have I had experience and encounters? And if I haven't, that's what internships are for, to get into an opportunity and just go out and learn about those different things. And more importantly, do I have the desire? Next slide. Now, I want you, before you go to the next slide, I want you all to think of this. Go back. I want you to take a picture if you haven't. because you're about to do a case scenario, and I want you to think of what I'm getting ready to share with you in this case scenario. The case scenario will enlighten you, and I will give you a little insight on some responses that I got when I did this presentation before. Okay, you got it? All right. Next slide. So we must ask ourselves and allow others to ask themselves those questions. Next slide. So why is cultural competence important? The term, as we've talked about, it relates to, remember I told you, it's not just culture does not mean it's 1 billion such and such, but culture also means ethnicities, religions, and various other perspectives. I want you to think of these terms when I share this case scenario with you. The challenge for dementia care providers, education researchers, and policymakers is adapting their approach to best support more inclusive structure, learn about diverse cultures and how to offer appropriate support, and understand how to work with a range of diverse communities. So this next slide, I'm going to now talk about how we're going to apply what you just learned. Let's go to the next one. It's a scenario. Here's the case scenario. I want you to hear it because you may not be able to see it. Mrs. W is a 79-year-old African-American female. She was born in Georgia, where she completed a sixth grade and later moved to California after marrying at a young age. I think she was about 15 or 16. She married her husband, he was in the military. They were in Georgia, and then they moved to California because military, the base is out there. She worked as a caregiver in a care home. That was her job, and during most of her adulthood, until she and her husband decided to retire in Arizona. That's nice. Her husband was a deacon, and she a deaconess at her church. Next slide. Next slide. Okay. Subjects. I want you to think of this. Subjects whose education level is 7th grade. Okay, so this is the question I was asking. So my question was, again, think of her, you all are familiar with MMSCs, MOCAs, and all that stuff. So think of her MMSC score, and I'm just kind of giving you an idea. MMSC's mini mental set. Okay. So education, so I want you to think of the subjects whose education level is 7th grade or lower, a score on the MMSC of 22, 26 or below. We adjust the score because of the education level. So if a person takes an MMSC and we find out that their education level is a little bit lower than the person graduating from high school, we may adjust their score. So take those things in consideration when you look at the scenario. Next slide. Was that the second one? Oh, go back. Sorry. Yes. Okay, go back, go one more. Okay, keep going. Keep going. Go. Sorry. Yeah, okay, that. Okay, MMSC score is not only do we take education effect, we also look at culture. So the MMSC does determine based on the level of education, the 6th grade level, but we also have to look at the culture of the individual. And I'm not putting this out there, but sometimes we also have to look at the geographical location. She's in Georgia, that's what she's born. So think of all of that. Next slide. Case scenario, we'll keep going. Mrs. W has 3 children, 2 sons of whom live in California, and the youngest, a daughter in Atlanta, Georgia. That's probably because she was raised in Georgia, so the daughter, okay. Mrs. W lived with her spouse and was his primary caregiver until around the time of her referral to Banner Alzheimer's Institute. Somebody referred her there, and she was his caregiver. Mrs. W medical history is Alzheimer's disease, early stage diabetes, hypertension, coronary artery disease, and osteoarthritis. That's what's going on with Mrs. W, but she was taking care of him. Next one. Common conditions for African Americans include depression, hypertension, diabetes, stroke, cardiovascular, osteoarthritis, and all that other stuff. Also are high risk for dementia. So these are things Ms. W have, and she also has high risk. Next slide. Keep going. Mrs. W is an 86-year-old, Mr. W, 86-year-old retired postal worker. He was a veteran, so he put a post up. Okay. His health declined physically, and that's why she was taking care of him. He was placed in a nursing home. Mrs. W, primary care provider, referred her to Banner Alzheimer's, obviously for programs, and also prior to her husband declining. Okay, think about that. I want you to family dynamics. After her husband's placement, the couple's daughter, we don't play as daughter. P, her name's P, flew in from Atlanta to visit her father. During her visit, because the mother called the father to come in to visit him. She didn't come in to visit for the mother. She said, sweetheart, your dad's doing bad. He's in nursing home, come and see him. So think about that. During her visit, she discovers her mother's diagnosis of dementia. You know how we are. We don't want to bother our kids, right? So here it is. She's like, wait a minute, something's going on with mom. Level of embarrassment. Mom didn't want to say anything. P began to take on the role as a primary caregiver, DPOA, financial, all that stuff. P came in for the father, but she okay, keep going. Reluctant to acknowledge her potential memory problems outside of the family for fear of embarrassment. That's what we do as African Americans, right? Next, and that's some other cultures too. Keep going. It's going to get deep. I want y'all to listen to soap opera right here. P is a school teacher who lives in a predominantly African American community, Atlanta, Georgia. She attended an HBCU. What's an HBCU? Do you know a lot of our providers don't know what that is? Okay. And she also belongs to several African American organizations. I think she's a Delta. But anyway, she has 3 children. Check this out. That's the daughter. One male son who was recently challenged with law enforcement, and her daughter was diagnosed with COVID. And P's siblings and her brothers, remember she's the youngest daughter. Very little support. Now keep going. Click, click. Historically, Black colleges and universities are institutions of higher education for the United States, and established this is a little information about historic Black colleges. I want to give you that. Amplified by, now her situation, she's the daughter. Her situation is amplified by her family situation. Son just got stopped by the police. Police said the daughter just got COVID. All of these was social unrest and the pandemic. Just that's what she's dealing with. And she's taking care of her family, her mother. She's tapping in for her father and found out her mother. Okay. Yep. Okay. Keep on. Keep on. Okay. As Mrs. PW health starts to decline, now the mother, Mrs. W, P begins to take on more responsibilities, taking care of her mother, visiting her father, began to become her new priority, both of them. Though accompanying her mother to BAI visits, she overlooked the program we have, Family Community Service Program. She was encouraged to attend some support groups, classes, participate in research. Oh, you should be a researcher. Mom got dementia, your dad got, you should get in research. Come on. But after a while, she stopped the visits. I don't need to go to BAI. And began attending her parents' church, First Institutional Baptist Church. And so then she said, BAI staff was struck by the number of times she declined the programs and also considered her as, you know how we do it, non-compliant. She's not participating, she's not getting help. Next, click. The lease report, go back. Click. Okay, yep. And then right there, the least reported social support need was for counseling from clergy, okay, 16.7%, which could indicate either high levels of support from the clergy. Now, what I want you to do before I go on, and I want you to now go to the next slide. Keep going, click on everything on here. Now, we have a large number of African Americans in here. I'm not trying to pick on you. Do you see this person as having high levels of stress, depression? Her scores would be high. Don't say yes. That's a hint. Her scores would be high. Why didn't she get support from family community services? She is non-compliant. No wonder she's not going to do well. What did we overlook? And I'll give you the hint. That last bar. Go back. Please go back to that slide, previous slide. Okay, click, go, okay, keep click, okay, click. So the last piece on there, I wanted you to see something that was overlooked by possibly healthcare professionals. And if you can't read it, I'll read it for you. The least reported social support need was for counseling from the clergy, which could indicate either high levels of support from clergy. Did you know, especially if we're not looking at it, if we're not culturally aware, and now we can go to the next slide. If we're not culturally aware, if we are not culturally skilled, knowledge, encounter, and also have a desire, do you know we could support that young lady with a high level of stress, because we thought the fact that she wasn't coming to our programs, but we never, like one of my colleagues I know very well who's in this room, we never looked into the fact that could she have gotten support from her family clergy? When we see that there's other outside support that these individuals can have, whether it's a Native American on a reservation, whether it's a Hispanic person with a family, overwhelming with family, or whether it's an African American person and the clergy and First Institutional Baptist Church deacons are talking to her about how they would support her without going to any of the programs that may be offered here. When we have a better understanding of what these culture needs are, we'll have a better understanding how to care for them, right? Go to the next slide. So case scenario, turning points. After attending the BAI conference, a BAI staff member reflected on the steps of cultural competence that Dr. Allen taught and had the ask model. And what that person discovered was he began to open up and talk to the staff about mistrust, issues with care, education. You asked me about research. You never asked how I was doing when I walked in there to talk to my mom, about my mom, her family, community, society, as well as how her son's recent situation with the law enforcement have caused her not to trust others. And even when it came to her parents' care, it was through P's interaction with that one staff member that there was an and P began to open up even more about possible interventions for African Americans that may be better utilized as resources. P was also realized how the resources she received from her mother applied to her father, how her mother's
Dr. Allen, please stay in the middle. We can't hear you.
Declination, and how easily accessible they were. Because did you know that a large number of caregivers, and I just got a call the other day, my mother just passed, and my father is going through dementia. And I want to know, can you give me resources? I said, sure. I told her about a great friend of mine that just so happened to be in this room on Hospice of the Valley. She said, no. My mom went through Hospice of the Valley. She's already gotten those resources. I said, my father has dementia. I said, and you can use Hospice of the Valley. But she didn't know. And here, she's even hinted on how she can get eaten. Guess what we just did? Because of the relationship she built with that one staff member that listened, she said, you know what? I'd like to learn more about your research projects that you have here. I may be involved. I may be interested. All because we became what? Culturally competent. Cultural humility is what happened. Next slide. So recommendations: build trust, improve access to healthcare, and provide one point of contact. You don't have to overwhelm individuals in the clinical setting. Provide one point of contact that would reach out to that individual and say, how are you doing? What are some of the things we can do to help you? I noticed you did not come to some of the classes we have. What are some of the resources that you use? Is this something that's often used in your culture? And increase cultural competence. Next slide. All research studies should take steps to be as inclusive as possible, including how research is advertised, using diverse images and culturally specific information. All the images should not look like one person. All the images should reflect what others do. Public involvement in research studies should include a range of diverse representation. As research funders, it is vital that research communities recognize the recruiting individuals from diverse communities takes additional time and money. We may have to spend that. Think of social determinants of health, and should also consider when awards are made. Researchers should ensure that there's a diverse range of peer reviewers assessing research applications, and that reviewers are knowledgeable about research and people with dementia and diverse communities. And last but not least, we know diverse communities are underrepresented as participants in research studies, so service managers who engage with and deliver services to ethnic minorities could be a key opportunity for recruiting people in studies. And if you go to the next slide, I think that wraps up. I thank you. The main thing, I love this. This is a statement that I always think of. Trust is built in drops and lost in buckets. All right. Thank you very much. And last slide, I think these are my little references. I appreciate you. And it is 3:15. So thank you so much.